Morning. Um, so I'm going to talk about some of the biomechanics of the regular fixators that you use, and also a little more about the biomechanics of the Ilizarov, because after all of these things have failed, you use your bone augmentation, use bone graft, use ultrasound, use electrical stimulation. Ultimately, for your non-union, you'll have to come to the Ilizarov. So better understand a little about the biomechanics. So what is the Ilizarov classically? What we say is the Ilizarov is a small wire fixator which is sort of circumferential in design with smooth and tensioned wires. But nowadays we more or less tend to use more of a hybrid fixator. So the question here is, what is optimal stability? Just putting in a lot of rings and a lot of pins or wires is not necessarily the optimal stability. There are many variables that come into play in case of all fixators, and we are going to try and see how we can ensure the optimal stability, because optimal stability is not rigidity. Rigidity is not a good word in today's day and age. It's an undesirable kind of stability. There is one instability which is desirable, that is axial controlled micromotion, right? All the other kinds of instability, that is angular bending, shear front to back or side to side, as well as torsion or rotation, are undesirable forms of stability. So you have this whole spectrum of stability, from very unstable to rigid. Unstable is a fracture which is not stabilized at all, and rigid is what used to happen with the earlier kind of delta frames, etc., or even with very rigid fixation, internal fixation that we used to do. Nowadays we are at this area where, generally speaking, with intramedullary nails, with bridging plates, etc., we are aiming for secondary union with callus. We are not aiming for primary osteonal union. So if you look at a uniplanar fixator, you can look at that, one in the plane of the fixator, and second perpendicular to the plane of the fixator, third in the axial direction. So here on your left side you see the fixator which is in the plane of the screen. In the middle you see the fixator which is sort of oriented perpendicular to the plane of the screen, and on the right side you are seeing an axial view of the same fixator. All fixators which are monolateral are effectively cantilever fixators. They have this cantilever effect where this end of the pin is fixed, and even if there is axial micromotion or movement of this fragment, it is always around a point which is here. So there is never any true up and down movement. It's always accompanied by a little amount of rotation which occurs around this point. So these the words which you see in green are the good sort of things, and what you see in red are the bad things. So here in this kind of fixator, in the plane of the fixator, the shear between the two fragments is minimal. There are axial movements, which is a good thing, but this is accompanied in variable degrees with bending. So to cut down this bending, the next sort of evolution of a unilateral fixator was to get a uniplanar bilateral, where you extend the pin across and put another rod on this side. But the problem, the good thing about this was bending movements were minimized, but the bad thing is that axial movements are also minimized. Now if you look at 90 degrees to the plane of the fixator, the bending movements are less. There is some amount of shear, and axial movement is negligible. If you look at these two, you will find that in the plane of the fixator and perpendicular to the plane of the fixator, the stabilities and the instabilities are exactly the opposite of each other, which led to this trial to try to increase the stability of the fixator by putting in two frames at 90 degrees to each other, what was known as the delta frame. You put in two unilateral fixators in a plane of 90 degrees to each other, whereby each cancelled out the other's instability. But this was the fixator which led to the bad sort of name for a fixator as a non-union machine. This required a complicated gradual destabilization. There are other variables which you probably already know, some of them being the distance from the bone. Therefore, you try and get your fixator rods as close to the bone as possible, as allowed for your soft tissue swelling and soft tissue dressing, etc. The thickness of the pin which goes into the bone, the thickness of the connecting rod or the diameter of the connecting rod, and probably the most important is the concept of fracture gap, which I'll come to later, which is internal stability. Today you have dynamic uniplanar fixators which basically are axially unstable by design. They are very, very rotationally stable, angularly stable because of this dovetail kind of design, but these clamps can slide up and down, and they are, you can do a controlled amount of axial instability with these fixators. So they take away some of the problems of uniplanar fixators. Now, one sort of big difference between the Ilizarov and other or standard fixators is the concept of linear and non-linear stiffness. In a Ilizarov fixator, as you take more and more weight, the amount of displacement increases initially till it reaches a kind of plateau. With almost all other uniplanar or non-circular fixators, the amount of displacement will keep increasing in a linear fashion as you increase the amount of load. And why is the Ilizarov more stable than the others? First of all, because it is circumferential, so you have 4 points of fixation all around the clock face. The Ilizarov works as an I-beam, that is the wire which goes from one end to the other is stabilized both on this end as well as this end, and therefore it can only go up and down without any angular motion, being a thin wire. So this allows actually for better axial micromotion, and all the other stabilities of bending, torsion and shear is actually equal, if not more, than any other fixator configuration. So for sort of long term use, probably the Ilizarov is a good fixator. For short term, where you just want to tide over a short period till internal fixation, it probably doesn't make a difference. The second question is, what is this axial micromotion? What is axial micromotion and what is macromotion? Studies show that probably less than 1 millimeter displacement at maximum load is the outer limit of axial micromotion. Within that, you will get an osteogenic response. More than that, you are not going to get an osteogenic response. So with the Ilizarov, there are a lot of variables that will affect the stability. We tension wires, you remember, with the Ilizarov, and the reason for that, these 1.8 mm wires, when they are tensioned, the stiffness of the wire and therefore the stability of the wire increases. So all wires with an Ilizarov fixator are usually at least tensioned starting from 70 to about 120 kilograms. Why do we tension up to 120 kilograms? The answer for that is in the strength of a 1.8 wire, that there is a certain point at which it breaks, okay, and another point at which it will yield. That is, instead of plastic deformation, instead of elastic deformation, you will have a plastic deformation, and that usually occurs at about 250 kilograms. So we take a safe limit of 50% of that yield point, which is about 120 kilograms. It's a good idea to tension these wires only with a dynamometric tensioner and not with the other Russian method that is shown, except in case of emergency. Your crossing angle of the wires, they should be crossing ideally at 90-90, but almost never in real life you can get this crossing in 90-90. So you should have at least a 30-degree crossing angle in between these two wires to allow for a reasonable amount of stability. You can use wires off the ring to increase the bending stability of your fixator. You can use olive wires which increase the resistance to shear. Also, in terms of the kind of pins that we use today, we tend to use still, I think, 4.5 and 5 mm pins. For long-term usage, for long-term retention, especially when you want to use it for any kind of reconstructive purpose, it's a good idea to use 6 mm pins, because with each increase in the diameter, there is a geometric increase. You already know about this from your use of intramedullary nails. You know, the stability of a 10 mm nail is geometrically increased compared to a 9 mm nail. It's not just that 1 mm of diameter. And same thing happens with a 6 mm pin. Now, one would argue that the I-beam effect is lost. That is true. The hybrid frame is less stable than the classical Ilizarov frame, but clinically there has been no real difference in terms of the healing. And finally, you have to also look at the bone factors, where you want, this is something which you already utilize very frequently with standard fixators also, where you want to be as far away from the bone as possible and as far away from the fracture as possible and as close to the fracture as possible. This is the concept of spanning the fragment. You have to hold as much of the fragment as you can with your fixation. In an Ilizarov, you can use it, you can use one ring with a drop wire, you can use 2 rings, and you can use 1 ring with 2 drop wires. The best is to use 2 rings, but many a time, whenever it's not possible to use 2 rings because of considerations of size, you can always use 1 ring and 1 drop wire. This kind of a configuration generally should not be used. Thank you.